Hello, my name is Erik.Mertens. I'm a cataract and refractive surgeon based in Antwerp, Belgium. And my talk is about avoiding surprises in my daily clinical and surgical practice with Solix. One of my favorite quotes is this: spectacular achievement is always preceded by unspectacular preparation. And Solix helps me to achieve this. When we look at the existing epithelial mapping technologies, you have the OCT technology and the VHF ultrasound. We have 5 OCTs, and 2 of them are able to capture a 10 millimeter diameter epithelial thickness map, which is the MS39 from CSO and the Solix OCT system from Visionix. The only VHF ultrasound capable of capturing the epithelial thickness map is the Insight 100 VHF called the ARC scan. But the downside is that the patient has to be immersed, the eye has to be immersed in water. So it's not so convenient than the OCT technologies. Now, the human corneal epithelium is pretty straightforward and standard. It has a variable thickness ranging from 40 to 60 microns, with mostly a slightly thicker inferior map. Why is it? Because it's the action of the upper eyelid which makes the superior epithelium mostly a little bit thinner than inferiorly. The epithelial thickness map is one of my favorite maps. It's actually the first map I look at. And you can detect different stages in dry eye with the epithelial thickness map. In mild dry eye, as you can see here, you have a thickening of the epithelium here in the inferior part of the cornea. When the dry eye becomes moderate, you begin to start to see thinner parts, as you can see here and here in the epithelium. And when it progresses to severe dry eye, the thinning continues, and the overall thinning is also marked in the center with lower thicknesses than 50 microns. So this map gives us a lot of information about what stage of dry eye the patient is in. On top of the epithelial thickness map, we always measure the non-invasive break-up time. As you can see here, it gives us a map with when, where does the tear film break up, at what stage, and how it is evolving. Why is this important? When performing high-performance IOL surgery, you want to be spot on. You need to be at plano after surgery. When you end up with -0.5, -1 or +1, the patient will not be happy. And when the eye is dry, the measurement and the K readings will be off. This is an example of a patient of mine with the IOL master before treatment and after dry eye treatment. And as you can see, the K readings are different, and the IOL calculated is in this case only half a diopter difference, but in many cases it's 1, 2, or even 3 diopters. But even a slight difference of 0.5 diopters will be the difference between a very happy patient or a so happy patient. Because as we all know, the dioptrical power of the intraocular lens is with a standard deviation. So you have a standard deviation of intraocular lens, you have false K readings, and you will not target plano after surgery. Now, the corneal epithelium in keratoconus is also very important, as you know, to make the diagnosis. In this case, you see that you have a thinning and you have a bulging in the anterior and the posterior part of the cornea. Now, when you have only a 7 millimeter epithelial thickness map, you can miss sometimes the epithelial thinning. As you can see here, this 7 millimeter epithelial thickness map captures here the thickening of the epithelium, but the thinning in this region is not captured. When we compare this with the 10 millimeter epithelial thickness map from Solix, it nicely captures here the thinning of the epithelium, which is at the same place as the bulging in the posterior and inferior part of the cornea, and you also can see the placido disc. So this is important that you have a 10 millimeter diameter epithelial thickness map to make sure that is a real keratoconus. Of course, it's an advanced state keratoconus, but in the milder stages of the beginning, you could miss the beginning of a keratoconus. Here, again, you see the 7 millimeter, and it misses completely the thinning in this region because it doesn't capture it. Now, by failing to prepare, you are preparing to fail. This, and also Benjamin Franklin said it many years ago. This is an epithelial thickness map of the MS39, of a normal epithelial thickness map in a normal patient. Now, we did this measurement with the Solix, and what did we see? We saw in the center a thickening of the epithelial thickness. And I wondered, what is happening here? So I asked myself, what could be the reason of those different maps? Could it be the sensitivity of the measurement, or could it be an incorrect measurement? So I did retake the epithelial thickness map measurement with the Solix on this eye, and guess what? A completely normal epithelial thickness map. Why did it happen? It was due to the fogging of the lens of the Solix due to the mask. So when you have an aberrant measurement, don't be afraid to remeasure, because it can be a faulty measurement. And in this case, it was just fogging of the lens. So this is very important, that you always be critical when you see a not normal measurement. Also, in cases with the recurrent corneal erosion syndrome, the Solix gives us a lot of information. As you can see here with the OCT of the cornea, you see this is a thickening of the epithelium, and then or otherwise normal epithelium in the rest of the cornea. This measurement was taken in the vertical meridian, and this part is the inferior part. We also looked in this case at the epithelial thickness map of this patient, and you can see here the characteristic thickening of the epithelium there where the recurrent erosion is taking place. So you can measure the evolution with the epithelial thickness map of a recurrent erosion, and also after treatment with a bandage contact lens, with drops, or with a PTK, you can measure this very nicely, and you can see and document it to the patient that this corneal erosion is healing or not. Another nice feature of the Solix is that you can capture the images with that instrument. This is a patient who had a contact lens in his eye continuously for 1 month, and he presented now with this very nice ulcus in his superior part of the cornea. We did more measurements with the OCT of the Solix, and you can see here a very large area with thinning of the cornea in this place. We also made a 3D capturing of this cornea, and by displaying this 3D, you can see we're measuring here in the cornea, so below the epithelium, and you can nicely see the borders of where the ulcus is. Here again, this is very important to follow up these patients with this kind of technology, so you can see the improvement, or when it gets worse, you can also evaluate this. Another great feature is when doing a pre-op evaluation, when you're doing refractive surgery or refractive lens exchange in general, is the HRT and measuring of the status of the optic disc. In this case, it was not known that the patient had glaucoma. He had 18 millimeters of mercury, but when we measure with the Solix the optic disc, you could see that there is a beginning here. It's very suspicious. So we put this patient on anti-glaucoma medication to make sure that he is not progressing, and we're following up, of course, with the Solix, so we can see in the future whether this is stabilizing or we need to change our treatment plan or not. Preoperative corneal screening is, of course, very important. As I told you, I always look at the epithelial thickness map first, and you can see here that there is an area of thinning. Specifically here, the superior part is not so significant, but here this is I was questioning what is happening here, and we looked deeper. I looked at the slit lamp, and it was pretty obvious that the patient had some subepithelial infiltrates. So the instrument is measuring here, just below the epithelium and Bowman's layer, and you can see these are herpes virus infiltrates. This is the right eye of the patient, and this is the left eye of that patient. And you can see this is a little bit different pattern of the subepithelial infiltrates. Again, you can have a look at the 3D imaging system, and you can see how large these infiltrates are in the cornea. Another great feature is the OCT of the retina. This patient was coming in for a refractive lens exchange with high performance IOLs to become free of glasses for distance, intermediate, and near. So the right eye of the retina was perfectly normal. The left eye, you can see there is a pucker. He was seeing 20/20 with each eye, so nothing was giving us a clue that there was something going on with the retina. And this is a higher magnification of his left eye, as you can see, and appreciate that the pucker is pretty extensive there. So we sent this patient first to the vitreoretinal surgeon to make sure whether he or she is giving us the feedback for we're going to go for surgery, or we are just waiting and seeing and treating it conservatively. This is another patient. Again, this patient was 20/20 corrected in both eyes until we saw this picture. It is a traction, a vitreomacular traction, and the patient was not aware of this. When you do surgery on this and you get a posterior vitreous detachment, which can be very aggressive, it can pull a macular hole. And then, of course, who is the patient going to blame? So I discussed this with the patient that he has this feature, and we did not do surgery on his eye, and we will wait. And again, we are sending this patient to the vitreoretinal surgeon to see what the feedback of the surgeon is. Postoperative evaluation is also very important. In this case, you can appreciate that there is some edema in the cornea. The epithelial thickness map looks a little bit different here in this region, but overall it looks pretty fine. And when we look at the deeper part of the cornea, as you can see here, it's at the posterior part of the cornea, you can appreciate the folds, and there are also decimate folds, but also folds in the deeper layers of the cornea. Again, you can evaluate and see the follow-up of these patients when with an adequate treatment, these problems will resolve or not. And in another case here, the postoperative evaluation of an implanted, an IPCL, which I implanted with a presbyopia correction. The IPCL comes with a diffractive refractive pattern, and we measure here in the center of the pupil and here at the superior part of the pupil. You can appreciate the rings which are in the front part of the IPCL and the decentration. There is a hole in the center of this IPCL, and it's decentered to one side. Another feature is measuring the vault of an ICL. You can accurately measure the vault in these postoperative ICL eyes and follow the vault in the future. As you know, the vault is highest in the beginning. The first 6 months, typically the vault of an ICL or an IPCL decreases. It still decreases after 6 months, but the evolution is not going that fast anymore after that period. This is a case of a lenticular extraction, which was performed with the ATOS from Schwind. You can nicely see where the cut was made here. It gives you very sharp images. It shows you the thinning of the pachymetry and again the epithelial thickness map. When there is a not good refractive result post corneal refractive surgery, the epithelial thickness map again will give you in most cases the right answer. And in this post smart sight eye, you can appreciate the cut in different directions. This is made in the vertical, but all of these measurements, these are 16 in total, will measure the cornea in all those meridians. This is a very nice example of a post-RK case. Many patients who had refractive surgery in the past, and the RK patients mostly had 20 to 30 years ago had their first intervention to get rid of glasses. They're coming now to see us because they want to still get rid of reading glasses. And the question is, can you perform a refractive lens exchange with implantation of a high-performance IOL or not? Again, the Solix will give us the answer. Is there a regular pattern in the center, in the pupil area? You can here see in the epithelial thickness map the cuts which are made. So it's very nicely shown here, that 8 cuts, and a typical thickening of the epithelium in the center. Also, when you look at the OCT and you are looking here also at the posterior part of the cornea, you can see that these cuts are pretty deep until in the posterior part of the cornea, as you can see here. And then you can make your decision whether it is a good candidate for refractive lens exchange or not. This is a very nice case. I did surgery on almost a year ago. It was a Cogan-Rees syndrome. As you know, Cogan-Rees gives a distorted pupil, as you can see here. And these cases also, most of the time, develop glaucoma. So because of the atrophy of the pupil, I could not do a reconstruction, an iris reconstruction to make a new pupil, but I inserted this morture ring. This is the view. This is the view of the at the surgery. You can see here that I placed the morture capsule tension ring with this artificial iris segment, and after surgery, it looked, as you can see here at the image, the pupil was really nice, round, and the patient could get a refraction back from 0.8 without correction. So in conclusion, if you don't know where you're going, you'll end up someplace else. Meaning, when you do not measure precisely the epithelial thickness map, dry eye, what is the cornea look like, looking at the retina, you will end up with surprises, and the patient will blame you as a surgeon. When you can capture this before surgery and explain it to the patient, you establish, first of all, a good relationship with the patient. He or she sees that you are a high-tech surgeon and taking everything into account to make sure that the surgery will be done as safe as possible. So in conclusion, the Solix gives us highly repeatably measurements. It is very fast. It is patient-friendly because you do not have to touch the patient's eye, and it gives me and surgeons using this instrument an added diagnostic value. I thank you very much for your kind attention.